Hello everyone. Our case is isolated naive tricuspid valve endocarditis in HIV patient due to Streptococcus pneumonia. Pneumococcal bacteremia can occur with or without pneumococcal pneumonia. When bacteremia is present, secondary complications may occur such as arthritis, meningitis, or infective endocarditis. Pneumococcal pneumonia represents less than 1% of all reported infective endocarditis. Our patient is a 47-year-old female with past medical history of HIV infection and CKD stage 4 who presented with complaints of left side pleuritic chest pain and shortness of breath for a month that was associated with fever and chills. She smoked 3 to 4 cigarettes daily for the last 10 years, occasionally used marijuana, but she denied alcohol or intravenous drug use. She got the HIV infection due to unprotected sex in the past, and she is not compliant with her HIV treatment. On a presentation, vital signs were significant for a heart rate of 110 and temperatures of 39 Celsius. On examination, cardiac exam showed a regular rhythm with normal S1 and S2, grade 2 systolic murmur that was heard in the left lower sternal border, and it was new compared to previous documentation in a previous hospital admission. Respiratory exam illustrated crackles that was mainly on the left lower side. On laboratory investigation, there was a mild leukocytosis, thrombocytopenia, and CD4 count were almost normal. HIV viral load was 2,700 and urine drug screen was negative. Chest X-ray was ordered and it showed left lower lobe infiltrate as we can see in figure 1, suspecting for left lower lobe pneumonia. Blood culture was ordered and the patient was empirically started on IV ceftriaxone and azithromycin. Blood culture came back positive for Streptococcus pneumonia that was pan-sensitive. Due to concern of infective endocarditis, especially with the pneumococcal pneumonia and bacteremia, new systolic murmur, transthoracic echo was ordered and it showed 1.9 by 1.5 cm echo density attached to the tricuspid valve leaflet as we can see in figure 2. For vital visualization, transesophageal echo was ordered and it showed a large tricuspid valve vegetation with perforation of the valve associated with moderate to severe tricuspid valve regurgitation as presented in figure 3. Figure 4, transesophageal echo showed a large vegetation of the tricuspid valve with central liquefaction. Surgery was recommended for the patient due to perforation of the valve, but she refused surgery, so medical treatment was given. Patient's clinical condition improved, and she was afebrile for 72 hours. She was discharged on ceftriaxone 2 grams to complete a 4-week course. Pneumococcal infective endocarditis remains rare, but carry a poor prognosis. It can cause rapid progressive infective endocarditis, extensive valvular destruction, and has a high mortality. Most common predisposing factor, as we know, for the right-sided endocarditis is IV drug use. Other predisposing factors include intracardiac catheterization, cardiac anomalies, or immunodeficiency. On systematic review of the literature since 2000, there were 111 cases of pneumococcal infective endocarditis, more predominantly involved the left side. Aortic valve was 53%, mitral valve was 40%. Isolated naive tricuspid valve endocarditis represent only 5 to 10% of all cases of infective endocarditis. So this case actually represents a very rare representation, as our patient had a right-sided endocarditis but has no history of IV drug use or cardiac anomaly or previously identified risk factors. So we learn from this case the importance of performing echo when we suspect infective endocarditis, especially in the presence of a new systolic murmur in pneumococcal pneumonia with bacteremia. Transesophageal echo favor early detection of the disease and its complication. A prolonged course of IV antibiotic for 4 to 6 weeks is required. Surgery may be needed in patients with symptoms of heart failure due to valve destruction or if there is a large vegetation or persistent bacteremia. Thank you.